our optometrist Shruti joining us. She'll join us shortly.
Oh, yeah. Oh, what's her name?
Her name is Shruti, sir.
Having
Shruti. Shruti. Yeah.
I have to learn to pronunciation, Natarajan. I haven't learned
Yes.
yet, but
Learned Aishwarya. I'm sure you learned Shruti also, sir.
yeah.
Here she is.
Hello.
Hello, Shruti.
Hello, sir.
Where is Varsha?
So she's on leave today.
Oh. So we have Shruti and Varsha doing the OCT and OCT angiography. So Shruti is my professor.
I will just share once more with the residents over here. Just a second.
Yes.
So how is weather likewise in India by now?
What is it?
The weather.
What is your question? Weather. October
Yeah.
in Mumbai is supposed to be a hot month, but it's cloudy.
It's
You can
cloudy.
see. It's cloudy. Yeah.
It was so hot here in our city, and
So
yesterday and today, no, actually
you can see.
this night we had some rain.
You can see it's a cloudy weather today. But otherwise, October is supposed to be a second summer in Mumbai only, Mumbai and Maharashtra. Rest of the country, it's stepping to winter in November.
Ah, okay. But
Or less.
is it hot enough?
Yeah, it is. Yes.
People are getting Carlos camera. Hi,
Jaydeep
good morning. Good morning, Jaydeep.
Hi, Jaydeep. Joining.
Good morning, Carlos. Carlos camera.
Yes.
Carlos
Carlos.
camera is a retina fellow from Goiânia here.
Yeah.
He's doing lots of vitrectomy by now.
Puja joined. Yeah. Okay, that's good.
Hi, Puja Gandula.
Yeah.
Your lecture last week was awesome.
Yes.
People loved it, and it's recorded. And you should go there to watch over and over again because we've been learning, with these new machines.
Yes. Hello, Jaydeep.
Hello, sir. Good afternoon.
Yes.
Hello, Jaydeep. How are you doing?
Hello, hello. I'm fine, sir.
So some more people should join us in a few minutes. We are live on YouTube as well. So things are arranging here. So Jaydeep, you are in Mumbai as well?
Yes, sir. Yes, I'm in Mumbai.
He's working with me.
I'm working with Dr. Natarajan only at Aditya Jyot Eye Hospital.
What is an honor? I want to visit you guys.
Yes.
When this
certainly.
pandemic, gets under control, and is there any hope for a fast vaccination or something more reliable? As we see, there are some studies and vaccination going on and things happening so far. Maybe not too soon, but Is there
I
any
think
hope
by
for
the end of
something?
2021, that's what they are saying.
Yeah. When the pandemic started, they said it could probably be ready in 6 months.
Yeah, they said it
Wait.
could possibly come by October, like possibly by this month, but it doesn't look likely now. Although the trials have started, but probably for it to reach the general public, I guess it will take some time. Plus, I believe the availability might be strictly, restricted. Maybe doctors would come as the first people who might get it because they are the high risk category. But general population, I believe it will be in a phased manner. Everybody may not be having get access to it immediately.
Yeah, I think so too. And we don't
Let's
know
hope
which.
it happens fast.
Yeah, that's it. We don't know which one we get first here. We don't know yet.
Yes, yes. How is the situation in Brazil?
It's getting under control, and especially in our city here, things are more stable. I think after we had some period of stabilization, after a while, things went up a little bit because the business were open to everybody, and people were going out, and not very many people. Most were wearing masks, but not many people. I mean, many people were not wearing masks, and so people kind of relaxed, and so they probably thought that wouldn't be so necessary. And so we
Right.
had this.
I think that's where India is at this stage. I think because everything has started off, the numbers are shooting up.
Yeah, that's it. Yeah. What about India? I'm reading and listening in the media that there's quite a bit more cases.
Yes, yes. So the cases are mounting up quite a bit, and I think they might be much more than reported because the testing in India is not as much as it should be or as it is probably in the Western world. So because of under testing, still the reported numbers might be less. Even then, they are quite high. So yeah, I guess it's not exactly a very great situation.
Yeah, we hope this is going to be under control. We hope and we want.
I just got the news that there's one case in my building today.
Oh,
This is the third one in the building.
oh.
Yeah, we have to take care.
Correct.
Aishwarya is here. I guess she's waiting to start.
Yes.
Yeah. I
Sorry,
think
I
so.
had
We
internet
are
trouble.
ready, Aishwarya.
Okay, sir. So can I share my screen? You have to let me screen share.
Anybody else is joining, sir? Pooja,
Yes,
sorry, Aishwarya. Anybody else planning to join?
Sir,
Any of your
no,
friends?
no, sir. Pooja is here. My friend Pooja. Shruti is sitting with me.
I will once more share the invitation here to the our main groups, and then the good thing that I think from this meeting is that we can interact. I think interaction is of utmost importance, and some people think that just watching later they might get some knowledge. I think so, but the good thing is to interact.
Yes.
And
Yeah, I agree.
Nageshwar is just coming, so I think we are ready. Good morning, Nageshwar. So we take off. So let's
start now?
let's start.
Is this
Okay.
screen visible?
Beautiful slides.
Okay, thank you, sir. Okay, so good afternoon, everyone. I will be presenting on OCT angiography. After a beautiful start to the basics on OCT by Dr. Jessica, I would like to take off from there. So OCT angiography is a non-invasive diagnostic method through which the vascular structures of the retina and the choroid can be visualized in 3 dimensions without the need for any dye or a contrast agent injection. So the basically it works by acquisition software and more advanced hardware, and the OCT angio enables us to image the retinal vascular flow. So let me just tell you about the principle. The principle is based on the principle of diffractive particle movement detection, such as red blood cells, on sequential OCT-B scans performed repeatedly at the same location of the retina, therefore showing the presence of blood vessels. So this method is based on the difference between the different OCT-B scans to generate a movement-related contrast, especially a contrast related to erythrocyte movement in the vascular system. So that's how it picks up. It takes multiple sequential OCT scans in one part of the retina. And with that, it forms an image of what the vessels in that area is like based on how the RBCs or the erythrocytes are moving in the blood vessels of that particular section of the retina. So to generate the image of the retinal microvascularization, each B scan of the examination pattern is consecutively repeated several times. So in the same cut, several times. The contrast comparisons on consecutive B scans at the same location reveal some areas with a contrast change over time and some areas with a constant contrast, that is same contrast. So the change in the contrast in specific location is attributed to the movement of erythrocytes or red blood cells, which therefore indicates the location of vessels. So then it forms the image it creates a 3-dimensional image of the blood vessels based on the movement of the erythrocytes in that particular area. As every OCTA obtained is essentially a cube scan, it is a 3-dimensional or a 3D assessment of the retinal vasculature, unlike traditional fundus fluorescein angiography or ICGA angiography, which is a 2-dimensional scan. So that is just going to show you one picture or like a photograph of one part of the retina. But this is going to show you all the layers of the retina, what the vessels look like in all the layers. That's why it's called a 3-dimensional scan. Now, coming to the evaluation, evaluate the scans from inner retinal surface right down to the choroid in a continuous manner. OCTA machines have taken the cube and split it into slabs. So imagine a cube and imagine if you cut that cube into slices. So each slab or slice is what it is going to give you the information about. Okay. So the first slab is the inner retinal slab, which extends from 3 micrometers below the internal limiting membrane to 15 micrometers below the inner plexiform layer. This incorporates the known anatomic location of the superficial retinal vascular plexus, which is generally what we see on a traditional fluorescein angio. So as you can see here, this is the inner retinal slab. Next comes the middle retinal slab that extends from 15 micrometer below the inner plexiform layer to 70 micrometer below the inner plexiform layer and incorporates the known location of the deep retinal capillary plexus. This is poorly seen on traditional fluorescein angiography, but it can be beautifully visualized on an OCTA. Then the outer retinal slab extends from 70 micrometer below the inner plexiform layer to 30 micrometer below the retinal pigment epithelium reference line. This region anatomically corresponds to a part of the retina within which there is never any vasculature in a normal individual. This is useful to identify type 2 neovascular membranes. So, I mean, normally if it's not there and then it's there, and then if the OCTA picks up some vasculature, that should tell you that something is wrong. I'll come to that in detail later. So the next slab is the choriocapillaris, which extends from 30 micrometer below the RPE reference to 60 micrometer below the RPE reference. It incorporates the choriocapillaris and allows detection of early type 1 choroidal neovascular membranes. Now
Aishwarya,
Yes,
I just want to comment on these labs. It's very important that you have a good software that gathers these labs necessary to see your pathology. Some
Yes.
softwares, they narrow down the area where you need these labs to be in. And so you might, as you said, you might get or you might lose the choroidal neovascular membrane type 1, type 2. And it's very important that you have the correct lab and that you adjust into your machine. And also, you could possibly vary whatever you're looking for in the size of the scan. If you get a too large scan area, you might lose, you might miss details that you don't see. But if you get smaller, like 3 by 3 or
Yeah.
5 by 5 or a less area, smaller area, you can zoom it in and you see better the vessels. So when you consider all slabs and the areas, and you should consider the whole, and the technician might not know where to look at. So you might have to tell him that you should see this area, photograph this area, and scan these areas, depending on the slabs, and you're gonna find the whatever you're looking for, like a choroidal neovascular membrane, for example, and then you do the whole thing. You do unfast or unfaced to see the whole thing and compare with the OCT, the normal OCT. And also, I think you're gonna talk about that during your talk about the advantages and
Yes,
disadvantages
sir. I will.
of
I will.
OCT, OCTA as opposed, especially OCTA as opposed to angiogram. And so I only do not do angiogram if the patient cannot have it done due to allergic and things and other problems. But these things complement. So your comments so far are so great. Thanks. You could go on.
Thank you. Thank you, sir. Another thing I'll add to what you're saying, sir, is that when we compare the OCT angio scans, so if we've taken one of 3 by 3 scan of a patient today, the next time we want to follow up the patient, we should remind the technician to do a 3 by 3 scan itself and not a 6 by 6, because that will not allow us to compare any progression after treatment, injection, etc. So what you said, sir, very, very pertinent. Thank you. Right. So moving on, analysis in OCT angiography. So I'll just deal with some terms that we'll come across. Segmentation. OCT angio produces volumetric flow information. So to allow for rapid identification and interpretation of pathological vascular features, there is segmentation of the anatomic layers. So the report is always given to you and in the form of a segmented report. Like each layer will be seen as a separate picture. Then there is end-phase projection. End-phase projection produces two-dimensional views of the segmented tissue layers. That is, in end-phase, what you are seeing like in front of you. Then slabs and slices, these refer to the tissue volume used for end-phase projection. Slabs refer to thick tissue sections, such as the inner retina or the outer retina, whereas slices refer to thin sections of a few microns used to examine the fine details. Then non-vascular flow signal. In OCT angio, background bulk tissue motion can generally be subtracted because it's associated with a uniform decorrelation. However, the decorrelation signal in some very highly backscattering structures can still rise above the background in some instances. These include RP, hard exudates, regions of pigment accumulation, thrombosed aneurysms, and retinal hemorrhages. Then there's something called the flow projection artifact. The shadowgraphic flow projection artifacts are the result of fluctuating shadows cast by flowing blood in a superficial vascular bed that causes variation in the OCT signal in deep layers. Then flow index and vessel density. The flow index is calculated as the average decorrelation value, which is correlated with flow velocity in that selected region. And the vessel density is calculated as the percentage area occupied by vessels in a selected region. So what is the density of the vessels in that particular scan, the cut that you have selected. Then avascular area. Avascular area is a significant area larger than the normal gap between the capillaries, devoid of flow signal on an end-phase angiogram. non-perfusion or capillary dropout area. This area refers to the avascular area that should normally be vascular. For example, on an OCT angio of the macula, any retinal avascular area outside of the foveal avascular zone is considered retinal non-perfusion or capillary dropout area. Then there is something called a neovascularization area. Neovascularization area is the sum of pixel areas in a pathologic neovascular net identified on an N-phase angiogram. Now, for example, in PDR or proliferative diabetic retinopathy, the area is of vessel growth above the ILM. In an age-related macular degeneration, the area of neovascularization is in the outer retina. So based on where you're seeing it, you will be able to come to a better diagnosis.
Yeah, and Aishwarya, it's interesting that some softwares, they eliminate these artifacts because oftentimes we see artifacts, and especially when the image is not so good. So we have some tricks to eliminate the artifacts, such as a good software and also the tracking. I like using, even though that takes a little more time for the examination to proceed, and the larger you make the photo, the picture, the scan, the more time you get to get the whole thing done. But I like using a smaller image or a medium image and the tracking system so that you have less artifacts. And these machines you're going to talk about, and some of them already have these artifacts elimination. This is very important for us to compare and not to be confused and then thinking that shadow over there, which could possibly be from a vessel above, could be a change or pathology in the outer retina.
Right, sir. So I'll just list out a few of the OCT angio systems. Zeiss Angioplex, the OptoView AngioView, the NIDEC AngioScan, the TopCon DRI OCT Triton. What we use here is a Zeiss Angioplex. No financial interest, just I know more about this, so I'm just going to describe this in a little detail. The Carl Zeiss Meditech Angioplex system, it's based on an upgraded Cirrus 5000 instrument, and it's a SD-OCT system which has an A-scan rate of 68,000 A scans per second with a light source centered on an 840 nanometer with a bandwidth of 90 nanometer. So that's really fast. And the system has an axial resolution of 5 micrometer, transverse resolution of 15, and A scan depth of 2 millimeters. The system incorporates a retinal tracking technology, like what Sir just said, the retinal tracking technology to track and compensate for eye movements in real time, as well as any shadows and artifacts, and using a proprietary algorithm which allows it to rescan areas which may have been affected by motion. So, you know, the patient often moves their eye while taking the scan. So how much can you tell them not to move their eye? So if that happens, instead of repeating the whole scan, the machine has the technology to cancel that movement out and not take it as as something wrong. Otherwise, it will show up as a lesion probably. But it is smart enough to cancel that out. It's called the tracking. This system also allows for registration between visits so that the exact same area can be imaged on consecutive visits. OCT analysis shows 6 end-phase slabs representing the inner capillary plexus, the outer capillary plexus, the outer retina, the choriocapillaris, the choroid vasculature, and the vitreoretinal interface, which should be normally avascular. So the Angioplex device uses the optical microangiography algorithm to generate the final end-phase OCT images, which we see on the report, instead of the SSADA algorithm. So coming to FFA ICG versus the OCT angio, scans can be acquired in few seconds and does not require intravenous injection. Then fluorescein or ICG angio requires multiple image frames taken over several minutes and can cause nausea, vomiting, rarely anaphylaxis. This means that the technician who is taking the scan, the FFA, should be perfectly well versed about what are the time intervals. So for different pathologies, you need to check out different time intervals more concentratedly. So you need to tell the technician that, I'm thinking about that there will be a problem in the late phase, so focus on that. And the eye also, you need to focus that early phase of the left eye, late phase of the right eye. So these kind of problems are eliminated in the OCT angio because it's very uniform all over. Then the fast and non-invasive nature of OCT angio also means that follow-up scans can be conducted more frequently and it'll be more accurate. Then dye leakage in fluorescein angio is a hallmark of important vascular abnormalities such as neovascularization and microaneurysms. Whereas in this, there is no question of dye and leakage. So that is one thing that, it's not in front. It's very difficult to counsel the patient because the picture is not there in front of them, and it's very difficult to make them understand what is it that we're trying to show them. Then OCT angiography does not employ a dye and it will not evaluate a leakage, like I said. It detects vascular abnormalities by other methods based on depth and vascular pattern, which is a little more complex, but more accurate. Okay, now dye leakage and staining do not occur in OCT angio. The boundaries and therefore areas of capillary dropout and neovascularization can be more precisely measured. So this is the flip side of it. And conventional angiography is two-dimensional, which makes it difficult to distinguish vascular abnormalities within different layers. So this is more precise. The 3D nature of OCT angio allows for separate evaluation of abnormalities in the retinal and choroidal circulations. So now again, we don't have to tell the patient you need to undergo an FFA as well as an ICG. So if you're suspecting a choroidal lesion, it's all there in the same scan. Now in clinical use...
just a second to comment. Sometimes in microaneurysms, for example, you may not see them as well as you see in the angiogram because the fluid, the blood, could be there, just stuck without any movement, and that is not a very good thing. So I won't be doing a OCTA just to see how many microaneurysms here and there, but it depends on the flow in the scanned area. You gotta see them as well, but it's good that you have the angio to compare as well, and also the angio and the OCTA to look at the areas that you mentioned slides before of capillary non-perfusion, capillary dropout. It's very interesting, and depending on the flow, whether it's too fast, you might get the OCTA scan as well. And if it's too slow and you have two different areas or three different areas scanned, and you might not see the image as well. So the software should be adjusted, or it's already adjusted to find the correct slab and way to look at these scanned images so that you can see. Because if you look at just one image and the flow goes too fast or too slow, you might not be able to see it.
Right, sir. Yes, very true. Okay, so coming to the OCT angio in clinical use, we have I've talked about a few of these conditions in detail: AMD, CNVM, diabetic retinopathy, arterial and venous occlusive disease, central serous retinopathy, MACTEL, that is macular telangiectasia, glaucoma, and anterior segment disorders. So it's basically all of ophthalmology, you can use it. So coming to some characteristics of what it looks like in type 1 neovascular AMD. So as you can see, the fundus photo here shows a macular drusen. The FFA showed an early phase hyperfluorescence of the drusen and a late phase hyperfluorescent staining with no obvious leak. And the OCT showed a drusenoid PED with mild subretinal fluid. So what will the OCT angio, what can we expect in that? That shows a CNVM complex deep to the retinal pigment epithelium. So in type 1 neovascular AMD, you will expect a CNVM complex deep to the RP. Then, so as you can see in this image, active type 1 neovascularization and color-coded highlighting of the vessel complex is what I'm showing here. There is a mature vascular complex with prominent feeder and dilated core vessels and finer interlacing and anastomosing vessels towards the periphery of the lesion. Coming to the next here, there is a medusa-shaped type 2 neovascular complex located above the retinal pigment epithelium, and a high-flow core feeder vessel is a likely entry point into the subretinal space. So this will show you that from where is the fluid leaking. So that shows the vessel, which is the likely entry point from the subretinal space, where is the fluid leaking, which is the source of the neovascular complex. I beg your pardon.
Get some water.
Yeah, just
Water is good to hydrate. And beautiful slides, the ones you showed before. And I see that it's important to consider also the fake color pattern. the color pattern is shown from above to below, from inner retina to our outer retina, and to simulate whatever the changes are, and it's interesting. But you have this type 2 very well shown, and you see on the left side on the angiogram, you see most of it looks like in the angiogram that is you see the whole membrane, and of course around the blood it's probably hidden in a occult manner, and so the OCT would look at it in a deeper analysis.
Yes, sir. So coming to type 3 neovascular AMD, type 3 neovascularization is the second most common form of neovascular AMD, comprising 30 to 40% of neovascular lesions in AMD. So previously it was known as a RAP lesion, that is a retinal angiomatous proliferance and occult chorioretinal anastomosis. So now we have now classified as type 3 neovascular AMD. So based on the SD-OCT imaging, type 3 neovascularization was proposed to represent the intraretinal location of a neovascular lesion. And subsequent studies have shown that these lesions originate from the deep retinal capillary plexus. A subtle hot spot in fluorescein angio or ICGA, or only on an intraretinal density with SD-OCT, may be appreciated. And OCT angio has for the first time identified the microvascular morphology of the type 3 lesions. A small high flow vascular tuft of smaller caliber vessels originating from the deep retinal capillary plexus of the outer retina. And in some cases, the type 3 neovascular complex extends posteriorly through the RP and may be associated with a large PD. In contrast to the chronic type 1 and 2 neovascular complexes that tend to horizontally radiate and branch out in a C-fan pattern, this one will not be so. It will extend posteriorly, and it will also be associated with a large thumb-shaped PED. OCT angio in early type 3 neovascularization with the appearance of a small tuft of vessels originating from the deep retinal capillary plexus. And this demonstrates the OCT subsequently of the same region will demonstrate a cystoid macular edema associated with a hyperreflective type 3 lesion located in the outer nuclear layer. Now coming to what does a fibrotic CNVM look like? It appears as a tangled neovascular network that appears as a high flow round lesion comprising of thin emerging branches with surrounding dark area, which is a avascular area, and or probably a leakage of fluid. Then in the OCT image of this particular section, the OCT angio image of the choriocapillaris segmentation and the corresponding OCT B scan will show a large flow void as a diffuse lack of signal, which is highlighted in blue within the high flow neovascular network. What does a PCV look like? Now, as you can see here, the photo, it's a little small, I know, but color photo 1 shows a rounded appearance of the macular reflection. This is more visible on the fundus autofluorescence next to it. And the intermediate phases of the indocyanine green angiography, the polyp is seen very clearly as a leaking hotspot. And the OCT scan will confirm the presence of exudates with localized elevation of the retinal pigment epithelium connecting through a right angle with the remaining retinal pigment epithelium. This is a serous retinal detachment. So OCTA, now what will that show? So end phase OCTA will show a rounded image that may correspond to the polyp as pointed out by the yellow arrow. And OCT angiography, the scans performed at the pigment epithelium detachment in the choriocapillaris and in the choroid will show vascular anomalies within the lesion, forming an abnormal vascular network called a branching vascular network, as I have shown in the red arrows. So that was what a PCV looked like. Now coming to diabetic retinopathy. In NPDR, OCT angio shows vascular remodeling bordering the foveolar vascular zone and some amount of capillary tortuosity and narrowing of the capillary lumen and dilatation of the terminal adjacent to the foveolar vascular zone at the superficial vascular plexus. Now the problem with this is that not all microaneurysms are perceived in both superficial and deep capillary networks, most probably because OCT angio is limited by the principle of slowest detectable flow. So microaneurysm will have it will not always get picked up, but yes, those that do get picked up will be very clearly visualized as highlighted in the yellow circles. Now coming to DME, OCT shows vascular loops and cysts both in superficial and the deep plexus, and end phase OCT is the best technique to outline the cystic changes that are seen in DME. It is the what we learn, the flower pattern of DME and all will be very clearly visualized in the OCT angio very beautifully, as you can see in these pictures. And the IPL layer appears to be the best location to appreciate this particular type of edema. Now coming to IRMA, intraretinal microvascular abnormalities or IRMAs are observed on OCT angio with reduced capillary density and adjacent non-perfusion areas. That is generally seen in severe to very severe non-proliferative diabetic retinopathy. And when it comes to proliferative diabetic retinopathy, patients with NVD and NVE, what we will see is that adjusting the OCT angiography slab towards the vitreous will allow you to clearly see that there is extension and morphology of the vascular network and useful in pinpointing exactly where the NVD is at or the NVE is in the retina. So like we said, the vitreomacular interface is supposed to appear avascular on OCT angio, but definitely if there is a front of NVE or NVD, it will be clearly seen on OCT angio.
Yeah, that's what I was commenting in the beginning, that we should adjust the slab to wherever we want to see the pathology, the things, the changes. And oftentimes the technician might not know what to look for. And so like you do in the angio, you photograph this area and this area. In the OCT, it's good that you adjust it to see this area and this area as well. So you have the whole picture of everything. These neovascular fronts are so well shown that there is no doubt that the patient is a PDR.
Right. It's very important to correlate clinically with what we see. Like just by we cannot just diagnose it purely based on the OCT angio. Like sir is saying, we must have a clear picture in our brain of what where we are looking for the lesion. Only then this will be able to help you to the maximum. Then coming to quantitative capillary perfusion density, OCTA color-coded capillary perfusion density mapping. Basically, this is a color picture. So like we have in the Pentacam and all these other scans, the color which will tell you exactly what the vascularity and the perfusion is like. So bright red represents a density that is of capillaries greater than 50%, that is perfused vessels. And dark blue is what shows you non-perfused vessels. So between dark blue to red, we have colors like green, light blue, yellow, orange. So that will tell you how well perfused it is. So dark blue being the least and red being the best. So capillary perfusion density mapping, here's an example. The first image shows the normal one with the foveolar vascular zone and surrounding normal perfusion. Then in mild NPDR, you can see that the red has reduced and moderate it is much less. And there are many spots of dark blue, very scattered. And in severe NPDR, it's much more, and PDR, it's pretty large. So you can see the dark blue, the size of the dark blue circle is increasing as the DR is progressing. So that will give you a very good idea of how bad the disease progression is. Now coming to arterial occlusions, color fundus photography demonstrates a retinal whitening with cherry red spot at the fovula and macular edema and increased thickness on OCT. So what does the OCT A show on CRAO? So OCT angiography of similar regions demonstrates flow void with more capillary detail. This will further enable enhanced visualization of the foveolar vascular zone. So the same thing can be seen on FFA as well, which is corresponding. So often these investigations will go hand in hand with each other and help you arrive at a more definitive diagnosis when in doubt. So coming to cotton wool spots, a cotton wool spot is something very acute, right? So the optical coherence tomography angio for cotton wool spot will demonstrate capillary flow void at the very superficial vascular network. This area of decreased perfusion appears smaller in the deep capillary plexus. Vein occlusion. Supratemporal BRVO is one example here. So on OCTA at the level of the superficial and deep vascular networks will show enlargement of the foveolar vascular zone and total disruption of the normal contour. You can see non-perfused areas, that is vascular loops, tortuosity, and microaneurysms. And cystoid macular edema will be very clearly visible, although the normal OCT will show you that, but this will show you an end phase picture of the cystoid macular edema, right? Okay. Coming to ischemic CRVO, magnified fluorescein angiography of a localized area superior to the macula, and vascular tortuosity, formation of collaterals, and areas of capillary non-perfusion as seen in picture B. Picture C which is highlighted in yellow, will show you the when you can do the manual selection followed by automatic calculation of the capillary dropout and non-flow areas at the level of the superficial vascular network, and the vascular density will get automatically calculated, and it will show you the color again, as you can see here in picture D. So CSCR related CNVM. Oftentimes we see that CSCR can get complicated by a CNVM, and late frame fluorescein angio will show this choroidal neovascular complex as an area of subretinal dye leakage, and the OCT will show a serous retinal detachment with a irregular PED. So the OCT angio at that level, at the level of the outer retina, will show a presence of a distinct vascular network representing the choroidal neovascular complex, and it will also be seen on OCTA scan taken at the choriocapillaris level. So basically, if we do this and we get a better idea that it's a CSCR which has gotten complicated by CNVM, we will be saving a lot of time, for diagnosis, and we can act fast. So some other applications for OCT angio in retina and ophthalmology are adult onset foveomacular vitelliform dystrophy, macular telangiectasias, high myopia, people who develop CNVM, lacquer cracks, chorioretinal atrophy, uveitis and retinal vasculitis, ocular oncology like melanocytoma, CHRPE, choroidal nevus, choroidal melanoma, choroidal metastasis, choroidal hemangioma, osteoma, to look for feeder vessels in all these oncological problems, and radiation retinopathy and anterior segment vasculature assessment. One of the areas where it's very useful is in glaucoma. So in glaucoma, there are two aspects where it can be of good use. One is that vascular dysregulation of optic nerve head and the peripapillary retina has been a risk factor for the development and progression of glaucoma. So using OCT angio, you can study the vessel density and perfusion in the various layers of the optic nerve head and the peripapillary area. And recently it's been showed that sectoral vessel density measured in the retinal nerve fiber layer will decrease prior to development of clinically significant retinal nerve fiber layer thinning and visual field deterioration. So imagine if you're able to catch that before the progression in fields as well as in OCT RNFL, which are supposed to be the earliest detectors for progression of glaucoma. So this is going to be much earlier than that. Another place where you can apply the OCT angio is to study the vascularity of a trabeculectomy bleb. So that's another application. Then coming to so I would like to conclude by saying that OCT angio has rapidly expanded as an imaging modality, and it has been used to qualitatively and quantitatively describe the changes in retinal and choroidal vasculature associated pathology. It also has the potential to enhance our understanding of the disease mechanism, since microvascular changes can be correlated to structural features. Currently, OCT angio is widely used in the clinical setting to guide treatment or diagnostic decisions. We still have to unearth a lot of technology related to this, and I think it will go a long way. So thank you so much for your patient listening.
Yeah, that was awesome. Great lecture, and also at the end of your lecture when we were talking about glaucoma, also I like doing OCTA to look at the optic nerve for those large drusen. They might compress somehow the vasculature over there, and they might cause some ischemia, either nasal or temporal. So this is good to see. And also, as you said, for glaucoma, to follow up on the nerve fiber layer thickness and correlate it with the other things displaying there. This is, very good that you pointed out so many details and with good examples. And so now I think we have more a better idea on how to look at the OCTA as compared to OCT as well, and the whole picture, doing the FA and the whole retina examination to look at a specific point so as to make a very good diagnosis. And this is a very good diagnosis tool. And we should rely on that. But not only on that, if we do not compare with the OCT, well, regular OCT, as Dr. Puja gave the lecture last week, and the angiogram as well. And considering that we cannot always rely on the angiogram, especially on those occult, choroidal, neovascular membranes, and it's good to look at the types. You pointed out very well the types of the membranes, type 1, 2, and 3, and to learn how to observe them in both OCT and OCTA. So it was awesome, you know. I was all slides were very well explained, and I might have commented before your slides and the things that you showed later, but that was good to emphasize.
Yes, sir.
Interesting. Thank you very much.
Thank you.
Jaydeep, what are your comments on the?
Yeah, hi.
Great
Firstly, yeah, I would like to congratulate Aishwarya for the excellent presentation.
Thank you,
Well,
sir.
covered everything and was very easy to understand. So, very, very good effort.
Thanks, sir.
So, what I understand is it's a very good tool now that we have OCT angiography, especially in certain conditions like AMD and diabetic retinopathy. And it's very good to use this tool. However, we should know the indications when we should advise this test and what to look for. And I think you highlighted that very well. So most important things are to know. You know, just give me a minute. It suddenly started raining very heavily here. Can you hear me?
Yes, sir, we are able to hear
Yes,
you.
sir. We're able to
Yes.
hear you.
Okay, yeah. So, as Dr. Hudson said, that it's very important to know the areas that we are looking here at, because the technician always doesn't know the segmentation, and most of the technicians, if not trained, they will give us the automatic segmentation which the machine software gives, and that might be very misleading when when you look into the scans. And this is one modality where you should definitely go to the machine and see, because you will never get an idea if you look at a printout of OCT angio and try to comment. So always go to the machine and go through all the segmentation scans. And I think most of the times, almost all the time, you will need to do a manual segmentation as per your machine and take it through the areas of interest. And only if you instruct the technician or you are yourself there, you can get the area of interest. So very good tool, and we need to use it effectively now that we have it, because as we all know, like we discussed last time, FFA is an invasive procedure and has its own set of complications. So for macular diseases which require follow up, like EMD, multiple follow ups, every monthly follow ups after injections, it's a very good tool to not only diagnose, also to follow up. So we should know what to look for when we are following up as well. So what are the signs of regression, and when you should consider it as a case where it is not going to respond to further treatment. All these things need a little finer study and experience. Also, these OCTs, I believe we should always look at them along with the structural OCT and not in isolation, because when you see a OCT angio map, if you don't know which if you don't see the structural OCT as well, it's difficult to understand. So always see the structural OCT, that is our SD OCT scan, and the area through which it is passing, and try to correlate the lesion along with the exact location of the lesion along with the OCT angio. So some conditions you mentioned, You can also look for them like pachychoroid neovasculopathy or some conditions where it's very difficult to pick up the neovascularization. So those are the places where an OCT angio really helps. So whenever in doubt, if you have OCT angio with you, you should consider using this tool and look at the appropriate slabs to come to a conclusion.
So, sir, like, can we replace ICG or FFA with an OCT angio, or do we always need to do that as well to confirm the diagnosis? So, if we are planning to, if we see that there is a patient with a wet AMD, and we plan to give the patient an injection as a form of treatment, intravitreal anti-VEGF. So, before that, we always prefer to do a angiography or an ICG to confirm our diagnosis, right? So, do you think OCT angio will be good enough to confirm that diagnosis and proceed with the treatment, or should we also do a fluorescein or an ICG to stay on the safe side?
No,
That yeah.
I think that's a very good question because I think it's a matter of debate in many of our meetings. So, well, you cannot take out FFA and ICG out of the equation even if we have OCT angio now. It is definitely there to stay in the future as well. And for certain conditions, it is the gold standard. Like in ICG, you cannot diagnose 100% on a OCT angio. So the answer would be if you cannot pick it up, if you don't pick something up, as I said again, if you don't pick it up on the OCT angio, then it's worthwhile doing an FFA or an ICG, definitely. But to start off with, if you can pick up a lesion on a OCT angio, I'm sure it is sufficient to not only diagnose but to initiate treatment and then follow up the patient.
Okay.
Because that's the whole beauty of the OCTA. You don't need to always do both because then it is not going to serve the purpose. So if you cannot pick up something on an OCT angio and you clinically suspect that there is something going on there, then basically you should go for a ICG or a FFA.
Okay, sir. Okay.
I like doing ICG for PCV, for example. I would do it if I had to choose from ICG or OCTA for PCV, polypoid. I will go on with ICG. Gives you a very good image.
Yeah, I still do the same. I do the ICG first whenever I'm doubting PCV. Unlike not the OCT angio. OCT angio probably comes after ICG.
All right. Pooja Kandula,
Sir.
you
Yes,
gave
sir.
us the last lecture last week.
Yes, sir.
And this was awesome as well. No, you both,
Thank you, sir.
as a
Thank you,
team,
sir.
I think you shared
Yes.
so many important things on the OCT on CTA. Do you have any comments on Aishwarya's?
Yes. I would like to congratulate Aishwarya for such an excellent presentation. Actually, we don't have an OCT angiography, so I have very little knowledge about OCTA to comment. But I would like to ask few questions, sir. As Aishwarya has already asked, if you are given if the patient is having PCV, what is your choice? Like you go for an OCTA or an ICG? And in diabetic macular edema, is there any special advantage of OCTA than the regular investigations which we do? And as sir said, Jaydeep sir said, we keep monitoring for the patients in case of ARMD with multiple injections. Sir, like in ARMD, we have OCT biomarkers, right, sir? So in OCTA, what are we trying to look for with multiple injections? Can you share your knowledge about this?
For multiple injections, I usually do only the OCT, unless you have something else to look at. Because it's easy to follow the edema, and especially on macular edema for diabetic retinopathy patients, for example, I like to measure, the whole thickness of the macula, the foveal central retinal thickness, and then you keep injecting, and then as you observe, the things are getting better, and the cases are pretty straightforward. So I don't have to look at the flow or whatever else, unless I want to look at this deeper and see the capillary plexuses and do the capillary dropout and ischemia and things that I also can look into the angiogram as well. So for regular cases in diabetic retinopathy patients, for example, I like doing just the regular OCT and the angio. But if you have choroidal neovascular membranes and you keep doing injections and you're repeating and you are deciding either treat in extend or treat as necessary, and then I would do OCTA as well. I like to follow, but oftentimes, as Jyot said, you might not be able to get the 2 exams at a time, and also concerns on the social questions there, and the patient might not be able in the public system to have them both performed. And answering the other question about the for PCV, that I would definitely do ICG and the angiogram and ICG. If I had to choose between these angiogram and I mean the ICG and the OCTA, I would rather do the ICG that shows better the lesions for PCV. And according to the studies, most of the studies, they don't display OCTA, but they display the OCT for injections and thickness measurements, and you see the visual acuity. I mean, the studies on diabetic retinopathy, the studies on CNM. There are quite a few studies that show OCTA as well, because it's easier to perform just the first ones rather than the later. And so that's why I think you have to select the cases that you choose for OCTA. If you can do both, better, but for the sake of maybe time as well, studies, and follow up on the patients in the daily clinic, you can get away with that by doing only the regular OCTs.
Yes, I agree. And as Pooja's question is, when you follow up a patient of NAMD, suppose an NAMD patient, when we are injecting, how do we look into OCTA? Well, there are few signs which you look into, like one is the lesion size on OCTA. Secondly, the peripheral looping vessels which are present in the active lesions, they start disappearing. The fine looping vessels at the borders of the vascular lesion, they start disappearing and shrinking, and slowly there is only mature vessels with a stalk, central stalk, and the mature vessels remain, so that are never going to go away. So those are signs of inactivity when you reach that stage, and the lesion size also decreases. So all this can be looked into when you are following up a patient on anti-VEGF injections in NAMD on the OCTA. As far as diabetic retinopathy is concerned, you need to understand that for diabetic macular edema, I would not be doing this using this modality much, because it gives some false results when there is a macular edema, because there are some void signals due to the edema. So since we are looking at the kind of blood flow through the blood vessels, it's not ideal for diabetic macular edema. But yes, for ischemic maculopathy or other conditions, neovascularization and microaneurysms, for example, or some vascular lesions can be picked up on the OCT angio, and it can be used in diabetic retinopathy for those things, and not exactly for following up patients with DME on treatment. And similarly, in other ischemic conditions, you can definitely use OCTA for follow-up, like a vascular occlusion, but it gives not very good results when there is a CME. And for PCV, as I think Dr. Hudson also said, ICG is the gold standard, and that is something I think we should use for a diagnosis. Maybe if you have both, and if you have done a OCT angio, you can follow up the patient on anti-VEGF injections or after PDT on a OCT angio. That can be done.
Okay, sir.
So that is for PCV. And any other condition you'd ask for, Pooja?
I think in case of VHL capillary hemangioblastoma, I think OCTA has better advantage over FFA. Is that true, sir? Like, can we know
VHL.
the better visualization?
I don't think, no, VHL it will be clearly, I think it will be in the periphery first of all. So doing OCTA there will be a little tough. You understand?
Yes, sir.
VHLs have multiple angiomas, so they are very well seen on the FFA, and I don't think you need to do an OCT angio for that, and it's in the periphery, so very few machines will have option of doing a montage on a OCTA like the Plexilite. The Plexilite is a swept source oriented or based OCT angiography machine from Zeiss, but very few centers have it, and it's only used for experimental purposes. Although at Shankar Netralaya we had a Plexilite, so it is possible to do a montage and a peripheral field in that. But other regular machines are mostly for the macula and the posterior pole, probably 6 millimeter into 6 millimeter scans. That's all. So tumors, I don't think unless they are at the posterior pole, you can use it.
Okay, thank you, sir.
Maybe capillary hemangioma, I think so. Yeah, capillary hemangioma is something which can be seen better if it's on the posterior pole. And choroidal hemangioma. If you are looking at a choroidal hemangioma, that will be seen better.
Thank you, sir. Thank you so much.
Great, Aishwarya. And
and one thing I forgot to add, last time we had a class on the FFA. I just remembered after the class was over. There is something also which is called as the oral fundus fluorescein angiography. So I forgot, because people should know about it, that there is something called oral FFA as well, because when you can't give the drug intravenously for some reason, you can give this dye orally.
Pediatric.
Yeah, pediatric age group. You can give it with some juice, and then I believe 2 vials or 2 or 3 vials of this 25%.
As far as I think 60 mg per. So I am not sure about the dose. So
yeah, it is mixed with 30 ml of juice and then given. And then after about 15 minutes, another 30 ml of juice is given. So after half an hour, you can start taking the images. But the only drawback of this oral angiogram is that you can't pick up the lesions which are in the early phase. You can only get the late phase. So any lesion you want to pick up in the late phases can be visualized on this oral angiogram.
Maybe a condition like vasculitis in pediatric.
Yeah, exactly. So
those
these conditions, it can be used. So you just keep it in mind that that is also one of the things which can be done.
all right, then. And we are going to be sharing next week the audio subject.
Do you use OCT angiography regularly?
In where?
No, do you use OCT angiography regularly?
Yeah, no, not very much so. I use when I have the indication. And if, as I pointed out, most of cases that we see in the regular clinic and practice are diabetic retinopathy patients, and I use mostly for choroidal neovascular membranes that are following. And as JD pointed out, if you want to see the extension and details on the membranes, and it's a very good tool. And I like using especially those cases that you have to follow up the patient for in the long run, that you are either using treat and extend or treat as necessary. So you keep following them. The myopic membranes, for example, that are recurring, and you have to keep on the treatment. And sometimes you don't know where and when to narrow down the treatment. For the treat and extent, for example, I usually start every month, and then I go 1 month and a half, 2 months, and rarely comparing to the Altair study for age-related macular degeneration for 3 months, but I'm not quite there. But then I would do more regular OCTAs with these patients if I want to look at their recurrence rates to actually get to the conclusion then that this specific patient, how long should we wait before getting the but especially for these a little more chronic patients, and maybe once at the beginning.
Okay. I'm thinking of, actually, I told I couldn't talk to Jaydeep. I know I heard your discussion. Jaydeep, I was suggesting to Aishwarya that wherever AMD patients, can we do a study of doing FFA, ICG, and OCTA for few patients and compare notes with the Hudson's patients and maybe have a joint paper. I don't know what we will get new apart from what is available in the science. But I thought, can we do a study in wherever patients accept to do all the three?
Yeah, good idea. I will separate some cases of so we could do this you know, like the study and maybe a paper and compare ICG, FA, and OCT, and OCTA as well.
Pooja has OCT angiography in Amrita?
No, sir. No, sir. We don't have an OCT angiography.
Okay. Aishwarya, we can find out whether anyway, I don't know whether I think we can do it with Hudson. Jaydeep, can we make a protocol so that we can fill it up whichever patients are ready?
Yes, sir. Yes, sir. We can do that. So we will be doing FFA, ICG, and OCT angio, all three you're saying, sir?
Yeah, that's right. That's right. In AMD.
Okay. In AMD. Okay. Yes, sir.
And see, if, for example, we have this Mr. Sushil Kumar Shinde who's going to come for a follow-up. Some OCT angio showing some changes, but the OCT is not that much. So I was thinking what to do. So something like that we can see even as a follow-up patient if the patient is ready.
Right. We can do that.
Okay. Yes,
all right. So I will do one separate protocol over here. And Jaydeep, maybe you could make a protocol as well. So we gather and see, and we arrive to a unique protocol, and we start this. This is going to be amazing,
yes,
yeah?
It's
going to be good.
We can do that.
All right, Natarajan, I leave it up to you for the...
Jaydeep?
Yes, sir.
No. The other review article, whether we can find... Hudson, we have a few patients with vascular occlusion. One Jaydeep has published last month in Indian Journal of Ophthalmology. And then second one, Aishwarya has completed it. And today, Dr. Akshay suggested not to send IGO because IGO is now not, listed for... they're going to remove it from regular IGO and put it in IGO case report. 18 months will not be PubMed indexed. Jaydeep?
Okay.
So we decided, I told Aishwarya to talk to you, to decide to put it in Women Journal of Ophthalmology or MIAJO. Both are indexed. MIAJO.
Yes, sir. Middle East Journal or Women Journal. Yeah. Sure.
Have you seen patients, Hudson?
No, not yet. For, as you mentioned...
Have you seen patients with the occlusion in your place? CRVO, CRVO, BRVO, due to COVID?
No. I have not seen them. Not yet. But you mentioned you had 2 cases?
Yes.
And one of them is published in the Indian Journal of
Thank you.
Ophthalmology. What about the
Second
CRVO?
Yeah.
It's on the track?
Yes. Probably, Aishwarya, can you send that publication thing, Sneha's paper?
Yes, sir. I'll send it.
Sure. You could possibly share us the link.
Yes.
So some patient might have skipped.
It will
from
come
my
up
eye, but I'm not sure.
in the November issue, sir. Once it's published, I'll send you the link, sir.
All right. Great. But the one from BRVO, you already have the link. It's already published, isn't it?
No, sir.
No,
It's accepted, sir. It is going to be published in November's issue.
Okay.
So maybe online will be a little ahead of publication. We have that when the link comes, we can send you ahead of.
Yes. Yeah.
So Jaydeep is writing a review article, and other one I'm thinking is we want to write a review article on epiretinal membrane with David Pelez. Hudson?
David Pelez.
Yeah.
Yeah.
So we are planning to write an article because I want to become member of the Gonin Club, and you need fresh 5 papers for publication for Gonin Club.
This is good. It's a subject that I like a lot to work with. It's epiretinal membranes and macro.
And me and Aishwarya also writing some review articles on trauma. Maybe we will send you wherever you are happy to take part. You can let us know.
Yeah, I'm happy.
So I
I'm
think
honored.
every week we can have a presentation, and then following that one talk on one discussion on a publication.
All right. So we could start next week.
I'm increasing homework for you.
Yeah, it's good that I could participate. And these articles, just please forward them to me, Aishwarya, if you could.
Right.
And
Yes, sir. It's out on the website. I'll send it to you, sir.
All right. And this article is planned for, it's already half done, or it's just we have to
The new article is on the pipeline, sir. We're working on it.
Okay. All right. So if you could give more details, and I would get some of my patients on the subject, and then I will put the article on the row as well.
Sure, sir.
Aishwarya, you told the next week's plan?
Yes, sir. I'll talk to him after this call because we're live on YouTube. We're streaming.
Okay.
Yeah. Okay, sir.
All right.
Okay.
So, Natarajan, I leave it up to you to close this knowledge reveal, this great lecture from Aishwarya, and with the participation of all of us. That was really, really great. We learned a lot from, and the good thing is
happy.
that I was telling them.
You rightly said, I didn't say. I mean, slides were excellent. I like always color and change all the time. I don't like the same pattern in every presentation. I'm glad Aishwarya changed it. It's good. You mentioned in the first slide, but I didn't want to interrupt her when she was presenting. Good. Very good, Aishwarya. I think
Thank you.
We can have, I mean, as I said, next week you decide. And then we have to slowly convert this into a textbook also one day.
Yes.
I actually suggested, like the Will's iBook manual, we should make a manual from these lectures.
All right.
We can make an e-book, not a print book, but we can make an e-book.
You can compile all the presentations and make a compilation of it.
Yeah.
Yes,
Yes.
Yeah.
Meanwhile, I have one suggestion. We can share these presentations in our WhatsApp group also for our reference.
Sure, sir.
That we keep, we can do that. And Aishwarya, you can keep all of them, store all of them and keep, so that we can make a ebook as far as saying.
Definitely, sir. Very good idea. I'll keep that.
It's worthwhile keeping these presentations as a, kind of a ready reference.
Yes,
Yes.
sir.
So that even when tomorrow you want to read, you can just go back to these and read the topic.
Yes.
Yes, sir. Perfect.
Great idea. Great idea.
And plus, we are also coming in omnivorous, which I think we have to officially send links to all the. We have actually asked for access for all of you in OmniCuris, because OmniCuris is only for India, they have mentioned, which is a public health company which publishes for CME credit. Okay, good.
So
I
thank
say we will
you
discuss at
very
6.
much.
Sure,
Aishwarya,
sir. Yes,
thank you
sir.
very much for your attention and
Thank you so much, sir.
everything.
Thank you for the opportunity.
Our pleasure.
Thank you, everyone. Thank you, Aishwarya, for the
Sir.
excellent presentation.
Thank you so much, everyone. Thank you, sir. Thanks for your
Bye-bye.
encouragement. Bye.
Bye-bye. See you. Have a great